So we're going to talk a little bit about hypertension. Hypertension is one of the big things that you're going to see in OB, and it can complicate a pregnancy very quickly and can go downhill very quickly. So we're going to kind of cover that. We might not have as much time in class, so I want to make sure that I get it covered here. And of course, my buttons aren't working. Okay, so hypertensive disorders in pregnancy. So I want to kind of think about what they are. So they're the, kind of the leading causes of maternal morbidity and mortality. So that just means that death in mothers and morbidity is sickness in others, in pregnant females. So there's 4 different categories that we think about when we think about gestational hypertension, or we just think about hypertension in pregnancy. So 1, there's gestational hypertension. That means they only get the hypertension while they're pregnant. Preeclampsia and eclampsia. We're going to go through those. Preeclampsia is before they have a seizure. Eclampsia is when they have a seizure. Then what happens if we have a mom that comes in that already has hypertension? That's chronic hypertension. So then can they get preeclampsia on top of the chronic hypertension? So those are the 4 kind of categories that we're going to kind of cover. So what is gestational hypertension? It is the blood pressure gets out of control after the 20th week of gestation, but they might not have protein in their urine yet. So they might not be starting those big complications yet, but we know that their blood pressures are remaining a little bit high, and this usually starts after 20 weeks. So their systolic is greater or equal to 140, and their diastolic is greater or equal to 90. So we're going to be watching those blood pressures very, very carefully. Some of these will resolve on their own. After the baby comes, the gestational hypertension will just go away. Sometimes it can predispose them to hypertension later on. If it continues 12 weeks after delivery, then we're going to tell them that they may always have chronic hypertension after that period of time. But this gestational hypertension can run into preeclampsia and then can go into eclampsia afterwards. So that's important to know. So we got our chronic hypertension and then the preeclampsia, eclampsia syndrome. So what the things that we're going to monitor for these moms, we're going to monitor their weight. So it's going to be really important to keep an eye on their weight. They will start to swell. Their kidneys aren't filtering as well, so you're going to see protein in the urine. Their blood pressure is going to go up, and you're going to start seeing some swelling in their feet. Antihypertensive may be prescribed, but we'll get to that here in a little bit because there's certain antihypertensives that cannot be given to pregnant females because it is tetragenic. So preeclampsia, eclampsia. Preeclampsia is the blood pressure that we talked about, 140 over 90. But now they've got protein in their urine. And this is usually after that 20 weeks like we talked about. So preeclampsia, their blood pressure is this, and they're getting some protein in their urine. So their kidneys aren't working like they should. Their kidneys are starting to mess up a little bit. They're not working like they should. Now, it's considered eclampsia once they have seizure activity. So it's preeclampsia before. Once a seizure activity occurs, now we have eclampsia. This may develop gradually over like the 20 weeks all the way into like delivery time, 36, 37 weeks, or it might come on very, very suddenly. A mom comes in, she's 28 weeks, she's complaining of blurred vision, headache, things like that. They test her. She's got, preeclampsia that goes very quickly into eclampsia, and we end up having to deliver a preterm baby. We don't really know why women get preeclampsia. It's just something that happens. There are some risk factors that we look at. So that's why it's important to do a family history. Usually it's going to be on the nulliparity, which means that it's going to be their first baby, first pregnancy. They might already have pre-existing hypertension, systemic lupus erythema, renal disease, diabetes. These are all going to kind of make them predisposed to this. Molar pregnancies, which we'll talk about those. Multiple gestations are going to be higher. They're going to be higher risk for gestational diabetes. So if they're younger than 20 or older than 35. So those are just some parameters to kind of think about. So those histories are going to be really important. So you're going to look at severe effects on the mom, and we're going to look at the fetus because we have 2 different people here. So mom, we may see seizures. So mom may start to have some seizures. She may develop pulmonary edema because of all the edema that's going on. She may develop what we call HELLP syndrome, and we'll get to that here in just a minute. She will get thrombocytopenia, which means that she's not got any clotting factors. So bleeding is going to become an issue. There's no really preventative therapy that we know of. One thing that is a recent study that just came out, that if we know a woman has had preeclampsia in the past, they will start them on a low dose of aspirin that first trimester, and that tends to help with the potential for preeclampsia later on in the pregnancy. No diagnostic tests that we can get that are going to predict somebody, so it's going to be very important that we monitor these moms. Again, that is exactly why we have to do prenatal care. So we see this and we catch this, and it's a standard of care that we need to be doing, early detection, so we can save these moms and babies. The primary problem that comes along with your preeclampsia is because the vessels are, so under so much stress, they can get vasospasms. And you know that the vessels that are going into the baby, we have AVA. So we got artery, vein, artery. The vein is going to actually carry the oxygenated blood. The arteries are going to carry the deoxygenated blood out of the baby. But what can happen is those can have spasms going into the placenta. If something spasms, and let's say this is your artery, and it clamps shut, you're not going to get the oxygen flow past that. So those babies can have hypoxemia. They can have some complications with that also. So that's one of the complications that we see. So these moms are going to have like elevated blood pressure, proteinuria, depending on, that's how we're going to classify it, whether it's mild or severe, if they have 1+ protein, 3+ protein. So we're going to look at all those kinds of things. Nervous system irritability, that's going to be your DTRs. So deep tendon reflexes. This will be if you take their leg and lift it up and you hit the middle of their kneecap and their leg goes whoa really quickly. That is going to be hyperactive DTRs. That's going to mean that their neurological system is very, very irritable, and seizures could be coming. We're going to look at clonus. That's when we take their foot. I know you can't see this in the video very well, but I take their foot. So we'd take their foot like this, and we would push their foot back. And then when their foot comes forward, it beats. It gets beats. And so we count those beats. That's called clonus. They will have severe headaches, blurred vision, double vision, spots in their eyes, nausea. A lot of them will complain of epigastric pain. And you think, oh, it's just heartburn. No, it's actually hypertension that if we don't really get down to it and look at it, you may misdiagnose it. So those are things that we need to look for. So once they have that seizure, it's now called eclampsia. Now we get complications of like aspiration, because mom is pregnant, she goes unconscious with the seizure, she aspirates, cerebral hemorrhage, stroke, because the blood pressure gets so high that it can rupture some of the cerebral vessels, hepatic rupture, abruptio placenta, and we'll talk about that, fetal compromise, that because the blood flow cannot get to the placenta, death of the mom or the baby. So if moms have eclampsia, even if they deliver the baby, she still remains at risk for postpartum during that postpartum period. So that 6 weeks after can also be a problem. Sometimes we have a lot of moms who deliver and they go home and we think their blood pressure is under control. They have a seizure at home and come to find out their blood pressure is extremely high. So now let's talk about HELLP syndrome. HELLP syndrome is a severe complication of preeclampsia. Not everybody will develop HELLP syndrome. HELLP syndrome is not super common. The only treatment for HELLP syndrome is delivery of the fetus. So that is the only thing we can do if the mom develops the HELLP syndrome. So it stands for hemolysis, which means that the blood's going to the red blood cells are going to be destroyed. Elevated liver enzymes, so we're going to look at their liver enzymes, their ALT, and all those kinds of things. We're going to look at the platelets, and their platelets are going to be low. Like sometimes we can get into like the 20,000s. So hemorrhaging is going to be a problem. These are usually we're going to see HELLP syndrome in severe preeclamptic women. Symptoms, again, is kind of the same thing that we talked about with eclampsia. So you can't always tell the difference. That's why these lab values are going to be very, very diagnostic as far as HELLP syndrome. So the epigastric pain, nausea, vomiting, sometimes they will have right upper quadrant pain. And the reason they have that right upper quadrant pain is because of the liver involvement. That liver gets congested and the liver starts to go into liver failure. And so that you get that right upper quadrant pain. So early detection is very, very important with HELLP syndrome. The only treatment for these, preeclampsia, eclampsia, is deliver the baby. So we're going to do very conservative management for mild preeclampsia. If they're mild, their blood pressure's not too bad, they got a little bit of protein, they got a little bit of headache, we're going to do bed rest. We're going to try to give them a non-stimulating environment. So we want to give them a quiet room, no TV, dim the lights, all that. We're going to have mom doing kick counts every hour, making sure that the baby is okay. We're going to be probably doing biophysical profiles. We're going to be looking at that baby. We may do an amniocentesis. Why would we do that? We're going to check for fetal lung development, because that's the only way we're going to know is if we do an LNS ratio to know if those lungs are mature. And then there's medications. So those are all the things that we can do to kind of help with that. The next thing that we can do is we can give them magnesium sulfate, and that will stop the seizures and help with the preeclampsia. And we may end up with oxytocin to help induce labor. So we're gonna talk to mom a lot about her. We're gonna start her on that magnesium. When we start on that magnesium, it's important to tell her that she's gonna probably feel some flushing. Her skin's gonna kind of flush. She might have some heart palpitations, and she might have some burning at the IV site. Those are all normal occurrences that are going to occur with MAG. Now, there are some hypertensive medications that we can use, but they're very, very controversial. Most of them have some type of tetragenic effects. So that's why we use the MAG sulfate, because we know that it is safe. It has lots of complications, a lot of side effects too, but it's safer for the fetus than other things. Absolutely no ACEs and no ARBs. They are documented tetragenic to the baby. So we would not do those. So what are we going to do for mom? Frequent monitoring vital signs. We're going to constantly be listening to her lungs, make sure she doesn't go into any kind of pulmonary edema. We're going to be looking at her swelling. We're going to be doing daily weights. We're going to be doing I&O. We're going to be providing a lot of support because she's going to be scared. She's not going to really know what's happening. Make sure that everything gets signed. Consent forms get signed. If she has any signs of things deteriorating, we got to make sure that provider knows that right away. She's going to have to be on bed rest. We prefer them to be on their left side. That just decreases the pressure going to the baby. We don't want the mom on the back, because when she's on her back, that growing fetus pushes down on the aorta and causes a decrease. They get hypotensive syndrome, and their blood pressure can plummet. So getting out of bed is going to be a big thing you're going to watch for. Teaching mom that she needs to let us know when she's having headaches, let us know if she's having any blurred vision, make sure that she's getting her medications. Now, also if you got a mom that's on MAG, who else is going to be getting MAG? The baby's going to be getting magnesium. So when you're getting magnesium, the magnesium is going to decrease all of their central nervous system effects. So the baby's also going to have some effects. So you need to let the nurses that are going to be taking care of a neonatologist know that we got a baby that's on MAG, because most of the time those babies are going to go to the special care nursery for a little bit to be monitored. So now let's kind of talk about chronic hypertension that also has preeclampsia with it. So this just means that mom had hypertension before she got pregnant. So she's going to be a little bit higher risk for her preeclampsia. Now, possible medical complications that can come from this was ventricular hypertrophy, which the ventricle can become enlarged because it's having to work so hard. Heart failure. The heart just can't keep up with the demands, because we know that when you're pregnant, the demands for the cardiovascular demands increase. We have an increased blood volume, cerebrovascular accident or a stroke, and kidney damage. So we know that all these things can happen because of this preeclampsia, especially if they have pre-existing. So we got to be watching for those. So we got to watch for placenta abruption, we got to watch our fetal growth, make sure things are going okay. So again, this is that blood pressure over 140/90 before or after delivery. So we got to just be watching for all those kinds of things. So ideally, we're going to start treating them for their blood pressure prior to them becoming pregnant. So we'd like to get their blood pressure under control before they get pregnant. That's why it's important that women start going to a doctor before they become pregnant, especially an obstetrician or a nurse practitioner that is in the obstetrics or gynecological field. That way they can talk to them about getting things under control, diet, lose some weight. What kind of work do you do? What kind of exercise do you do? How can we get you in a better state before you come pregnant? So that's going to be really important. Those prenatal visits, they need to make their prenatal visits. We're going to have to make sure that we do all their fetal surveillance, make sure we're really looking at that baby. So all those are things about hypertension. So make sure that you do look at magnesium sulfate. So I think we'll cover it in another section, but magnesium sulfate will decrease the central nervous system. So they will become very lethargic. Their DTRs will be they won't have any. So if you find a mom and you started her out on the MAG and she had really high hyperexcitability DTRs, we can see where they don't have any. So they start to become very lethargic. They will start to become have difficulty breathing, and sometimes their respiratory rates will go below 12. If you get a mom that's on MAG and the respiratory rate goes below 12, you have to let the doctor know, because they will have to back off on the magnesium, or if sometimes their respirations might even get down to like 10 or 8. Baby's not getting perfused if they're getting that far down. So we're going to have to give them something to counteract the magnesium, which is calcium gluconate. So just know a few of those little things, and that may be helpful. So hopefully that's been a helpful trick on hypertension.